chalky white deposits. So conditions like acute pancreatitis. What happens in acute pancreatitis when the pancreatic lipases or just liberated, these lipases will try to liberate this, release the triglyceride esters. So the lipases will release the triglyceride esters. So in that case, after this triglyceride esters, fatty acids will be generated and calcium will be combining with the fatty acids. So calcium plus fatty acids, this gives rise to this saponification. So saponification with calcium salts. Now you will be remembering. So calcium salts, saponification. So calcium salts, it will be appearing as a basophilic material. Please remember that what I told you in monkey bird's medial sclerosis. Yes. Okay. So what are all the other causes? Yes, fat-rich organs like breast, buttock regions after a trauma. Okay, after a trauma, fat necrosis can be there. So what you can see here in the histology, you can see this basophilic material. Can you see this basophilic material? Now you will be remembering basophilic material. If you see, that is calcium salts. Yes, this is calcium salts. So calcium deposits. And what you can see is, you can see this, the cells, the fat cells will be appearing like a shadowy in appearance. Shadow outline of the fat cells will be the shadow appearance of the fat cells will be there. So this shadow appearance, cloudy appearance, this can also called as the cloudy appearance. Normally how the fat cells will be looking, like they will be having a well circumscribed border. So but see here, it is like a somewhat a shadowy or it's a cloudy appearance. So think of the fat necrosis. Please remember that, fat necrosis. So this is a case of a fat necrosis. Chalky white deposits, you should not mess it. Okay. Then a person after autopsy, a person who has died, and during the autopsy after some 2 days or 1 day after that, what changes you can expect in the brain? Yes, if you remember, if you hear the word brain, you can remember the other, what is the type of necrosis? Brain. Yes, liquefactive necrosis. So brain, you can get liquefactive necrosis. Which are all the other conditions you can get liquefactive necrosis? Pus, abscess. Yes, pus, abscess, in all these conditions you will be getting this liquefactive necrosis. Please remember that, liquefactive necrosis, that is liberation of the hydrolytic enzymes by the brain. You can get this liquefactive necrosis. Yes. So this is going to be the next image is going to be a very important thing. That is actually, if you see blood vessel. So if you see a blood vessel image and there is a history of vasculitis. Okay, if you can see the patient is having a vasculitis related symptom. And if you can see in the blood vessel, what is the finding you are seeing here? Bright. Yes, this is nothing but how it appears. This is a bright eosinophilic material. Can you see this? This is the bright eosinophilic material which you can see in the vessel wall. You should think of fibrinoid necrosis. You can think of fibrinoid necrosis. Usually what you will be learning, epithelioid, na, like epithelium, like you will be knowing, but fibrinoid means actually it is fibrin only, but fibrinoid, it is fibrin only. Why there is fibrin which is deposited in the vessel wall? Imagine a immune complex disease, say for example in the SLE. So SLE or in any case of vasculitis. So what happens? The antigen antibody will join together. The antigen antibody complex will be forming and the antigen antibody complex will be deposited in the vessel wall. So this will be causing the liberating the all your chemical mediators, cytokines, and this will be damaging the vessel wall, resulting in the inside the blood you will be having the fibrin, no? Inside the blood you will be having the fibrin, no? So that fibrin will be leaked out. So inside the blood vessel, the fibrin will be leaked out and it will be deposited in the vessel wall. And this is that fibrinoid necrosis. Yes, vasculitis. In any vasculitis, you can get this. Most of the vasculitis, you will be getting this fibrinoid necrosis. So bright eosinophilic material. Also, you have to keep it in mind, fibrinoid necrosis can also be seen in rheumatic fever. Acute rheumatic fever. Yes, acute rheumatic fever. No, you will be remembering the pancarditis. No, pancarditis, you will be remembering the Ashkoff bodies. No, so Ashkoff bodies, you can get this fibrinoid necrosis. So fibrinoid necrosis is seen in the Ashkoff body. So malignant hypertension. Yes, Sally. So these are all the other causes of your fibrinoid necrosis. Fibrinoid necrosis. Okay. Yes. Now, a few words about the gangrene. Yes, you have two types. What is gangrene? Gangrene is nothing but necrosis with superadded putrefaction is the gangrene. Yes. So gangrene, mainly you have two types of gangrene, dry gangrene and your wet gangrene. Dry gangrene and wet gangrene. Dry gangrene, where you will be getting? Yes, in the acute rheumatic fever, Ashkoff bodies will be seen in myocardium, pericardium, and endocardium. All the three layers you can see this Ashkoff body, but they are more commonly seen in the myocardium. In myocardium, you will be getting the Ashkoff body commonly. In Ashkoff body, you can get fibrinoid necrosis. You can get fibrinoid necrosis. Yes, dry gangrene usually you will be getting in the limbs. Okay, the classical example, very good, very good. TAO, thromboangiitis obliterans. So what happens? The blood vessel, there is a arterial occlusion. So there is a arterial occlusion. So arterial occlusion resulting in the ischemia and gangrene of the foot, that is dry gangrene. Whereas in the wet, usually the moist areas, bowel. And please remember diabetic foot. This can be asked as an integrated question. Okay. So with a surgery, they can integrate this. So diabetic foot, what type of gangrene you are getting? You will be getting this wet gangrene where there is a venous pooling. Okay. It is mainly the venous pooling. Okay. Venous pooling, you will be getting this gangrene, wet gangrene in the bowel. So please remember. And one important point, in dry gangrene, you will be getting a line of demarcation. You will be getting a line of demarcation between viable and the dead tissue. Line of demarcation between a viable and dead tissue. Viable and a dead tissue you will be seen in case of dry gangrene, but in wet gangrene, there is no line of demarcation. There is no line of demarcation. This is very important. This is very important. Yes, very good. Bed sores, that moist area, keep it in mind. The where is there is a venous pooling and the moist area, you will be getting this wet gangrene. Then gas gangrene, especially in a road traffic accident, when there is a contamination of the wound by this bacteria, especially the Clostridium, you can get this gas gangrene along the muscle plane. So this is a quick view about this gangrene. Okay. Yes. Now moving on to the other important topic. Yes. This is actually a person of lichen planus. So this is actually a squamous epithelium. So squamous epithelium. So I am taking an example of a lichen planus or anything. So you can see what is the change you are observing here. The cell size has shrunken. The cell size has shrunken, and the apoptotic the cell size has shrunken, and serum electrophoresis is revealing this pattern. So what is this changes? Now we'll be taking this as an example, as a thing to demonstrate or to discuss about the apoptosis. So apoptosis. Yes. Can you think of the which other? Yes. Very good. Very good. So in the electrophoresis, this is the normal pattern. Okay, this is the normal pattern. You will be getting this, and in here you will be getting this step ladder pattern. And step ladder pattern, if you see, that is characteristic of apoptosis. Very good. This is the smudging pattern, smudging or smearing pattern, which you can get it in a necrosis. Smudging or smearing pattern, which you can get it in the necrosis. So let us recollect what happens in the apoptosis. Physiological causes of apoptosis. Please remember, physiological, where are all the things that apoptosis can occur. So the question can be framed. where you can get it. They can give you a clinical scenario. What is the pathological process which is responsible for that, like, or thing which would have occurred there. So you can remember physiologically also apoptosis can occur in case of embryogenesis. Yes, embryogenesis, organ formation. Then neutrophils. Neutrophils are the cells which is coming in an any acute or stressful condition, first line of defense. So after their job is over, the neutrophils will go in for apoptosis. The neutrophils will be going in for apoptosis. Then endometrium, very good. Endometrial shedding. Yes, during menstrual cycle, during the menstrual phase, the endometrium will be shedding. No, so the endometrial shedding occurs during because of apoptosis, because of apoptosis. So these are all the conditions. And also in auto means to prevent autoimmunity, self-reacting lymphocytes die. Body kills that self-reacting lymphocytes by apoptosis. Then pathologically, where you can get apoptosis? Pathologically, you can get apoptosis when you get a cell which is getting damaged either by a radiation or a chemotherapy or chemical mediated mutation occurs. Body will not allow that cell to divide. So that cell will be going in for apoptosis. Then protein misfolding. You must have heard of protein misfolding condition. Misfolded proteins, those cells will be going in for apoptosis. Very good. Hepatitis, infections like hepatitis, HIV, you can get this apoptosis. Yes, now you will be remembering councilman bodies. Yes, very good. So councilman bodies, where you will be getting councilman bodies, you will be getting in hepatitis. They are nothing but apoptotic hepatocytes. They are nothing but apoptotic hepatocytes. Yes. So councilman bodies, and any organ which has got the duct got obstructed. Say for example, salivary gland. A stone is obstructing the duct. The organ will go in for apoptosis and will be atrophied. So remember, in all these changes, you will be getting this apoptosis. So apoptosis, what are all the two pathways you remember? Initiation, what are all the two pathways? Extrinsic and intrinsic pathway. So intrinsic, you will be remembering. Mitochondria. So mitochondria. So now you will be also remembering the anti-apoptotic genes. Yes. What are all the anti-apoptotic genes? Yes. It is BCL2. Yes, BCL2, MCLHL. Yes, very good. And apoptotic, you will be remembering backs and back. You will be remembering. Then what are all the BH3 proteins you will be remembering? BH3 proteins. BIM. Bad. Yes. Then what else? Yes, BIM. Bid. Yes, very good. Then Noxa, Puma. So all these things are all the BH3 proteins. So please remember, these are all the proto-oncogenes. One important concept you have to remember: proto-oncogenes can serve as both apoptotic as well as anti-apoptotic. Proto-oncogenes can serve as both apoptotic and anti-apoptotic. So intrinsic pathway, that is the mitochondrial pathway, actually what happens, normally the cytochrome C will be inside the mitochondrial membrane. And what happens in intrinsic pathway, the cytochrome C, which is inside the mitochondrial membrane, will be leaking out and it will be activating the caspase. So intrinsic pathway, which caspases are activated? I told you to remember NIAN. Okay, I told you to remember NIAN. So NIAN, caspase 9 is getting activated in the intrinsic pathway. Very good. Then extrinsic pathway, that is via the death receptor. Extrinsic pathway via the death receptor. What are all the death receptors you know? Yes, FAS and FAS ligand. Yes, what is the marker for apoptosis? CD marker for apoptosis. Yes, can anybody tell me CD marker for apoptosis? It is nothing but CD95. Very good. CD95 is the marker of apoptosis. Then you will be having the death receptor. That is Also, you will be having the TNF. Remember, tumor necrosis factor. So, extrinsic pathway will activate the caspase 8 and 10. 8 and 10. So, both these things will be activating the apoptosis, and both these things will be activating the apoptosis executional caspases. So, intrinsic and extrinsic together, they will be activating the caspase 3, 6, and 7. These are all called as the executional caspases. Executional caspases. Page number 6, I think. Executional caspases. Executional caspases. Yes, now they will be cleaving the nucleus. Endonuclease will cleave the nucleus. So only you are getting this step ladder pattern. You are getting this step ladder pattern because the nucleus is getting cleaved. The nucleus is getting cleaved. Okay. So, and what is the, and you will be getting a formation of the apoptotic bodies. And your phagocytosis will occur in the apoptotic bodies. The macrophages will engulf the apoptotic bodies. And what is the process of phagocytosis? What is the process of phagocytosis which occurs in apoptosis? Yes, efferocytosis. Efferocytosis is nothing but the process of engulfment of the apoptotic bodies by the macrophages. That is phagocytosis of the apoptotic bodies. Efferocytosis. So apoptotic cells, how you will be looking? It will be, the cell size will be shrunken. Yes. Can you name some special stains for apoptotic cells? Demonstrating special stains for apoptotic cells. Yes. Anybody? Special stains for apoptosis? Yes. Annexin 5. Fulgen stain. Yes. Acridin orange. Do you know any assay for demonstrating apoptosis? Yes, very good. Tunnel assay. So all these things you have to remember in need of in case of apoptosis is asked. Okay. So, and also please remember an important difference between the apoptosis and necrosis. Very, very important point. Apoptosis can be physiological or pathological. But necrosis is always pathological. Okay, and another important point, inflammation will be absent where the inflammation will be absent. Yes, inflammation will be absent. Why the inflammation will be absent? Because the apoptotic bodies are there. The cell membrane is intact. But in necrosis, the cell membranes are destroyed. So there will be leakage of the cellular contents. So inflammation will be always present in case of necrosis. Inflammation will be always present in case of necrosis. The cell size will be shrunken in case of apoptosis, whereas the cell size will be swollen in case of necrosis. These are the important points we have to remember in case of apoptosis. Yes. So now coming on to the next image. Yes, this is an image of a cardiac tissue of a patient of some 60 or 70 years old. Yes. So cardiac, if you hear the word cardiac, you can see the striations. Can you appreciate the striations here? Can you see the striations? So cardiac muscles are striations, and you can see the nucleus. You can see the nucleus in the cardiac tissue, and around the nucleus, that is perinuclear location, you are getting this brown pigment. And it is a case of a old age. So please remember elderly age group. This is the lipofuscin pigment. Okay. What is the other name for the lipofuscin pigment? Lipochrome pigment. Other name, wear and tear pigment. pigment. Okay. Then only aging? No. It can be also seen in malnutrition. In case of malnutrition, also you get this lipofuscin pigment. Wasting illness. Okay. Any wasting illness after radiotherapy. After radiotherapy. So all these conditions you can get this lipofuscin pigment, which is actually in the perinuclear locations. Perinuclear location. So it is actually tells you that free radical mediated injury. This lipofuscin pigment tells you that there is a free radical mediated injury. Free radical mediated injury. Okay. And what happens here? Lipid peroxidation. These are all the key words. Okay. Lipid peroxidation occurs in the lipofuscin pigment. And what changes? Yes, very good. Aging pigment, cancer cachexia. Very good. Radiotherapy. Radiotherapy, wasting illness, radiotherapy. Okay. Lipid peroxidation. Yes, polyunsaturated fatty acids. Very good. Lipid peroxidation. So, what is a special stain for to demonstrate lipofuscin? It is Long-Zeal-Nielsen. Long-Zeal-Nielsen stain to demonstrate the lipofuscin pigment. Long-Zeal-Nielsen staining. And in the heart, what is the change you can expect? Brown atrophy of the heart. Brown atrophy of the heart. So what are the things you can recollect? Lipofuscin, other name is lipochrome, that is a wear and tear pigment. It is thin in elderly age group, and wasting illness, malnutrition, radiotherapy tells you that there is a free radical mediated injury, and lipid peroxidation occurs here, and you can get this brown atrophy of the heart and also stained by Long-Zeal-Nielsen staining. Okay. So this is, you remember, cardiac muscle, nucleus, perinuclear location, lipofuscin. Yes. So on seeing this picture, what are the things which is coming into your mind? A child presenting with a repeated and persistent infection. The child is presenting with a repeated and persistent infections. And on the peripheral smear examination, the neutrophils will be having the giant granules. Okay. These are all the giant granules in the neutrophils. So neutrophils are having a giant granules. And you can also see such giant granules in the platelets also. The child is presenting with a albinism. You can see this albinism and silvery hair. Okay, the hairs appear silvery. So silvery hair. Peripheral neuropathy, thrombocytopenia. So all these things, if symptoms are there, yes, very good. It is the Chediak-Higashi syndrome. Chediak-Higashi syndrome. So there will be a history of repeated infections will be there. Chediak-Higashi syndrome. And it is a mutation in the list gene. Okay, the mutation is in the list gene, and there will be a defective in the phagosome and lysosome. So phagocytosis, what will happen during phagocytosis? Phagosome and lysosome will fuse together to form a phagolysosome. So that fusion will not be there. Defective fusion of phagosome and lysosome will be there in case of Chediak-Higashi. So that abnormal phagolysosome, those fused products will be appearing as the giant granules in case of neutrophils and in case of the platelets. Remember, in this history, it is the inheritance of this Chediak-Higashi syndrome is autosomal recessive. So let us take, so if you can see this, a child with oculocutaneous albinism and the silvery hairs and giant granules in the platelets and neutrophils, think of Chediak-Higashi syndrome. So let us take this opportunity to quickly revise the cellular events. So which is the thing, which is the molecule which is needed for the rolling? Which molecule is needed for the rolling process of a thing which occurs in the cell? Rolling, adhesion, cellular events of inflammation. You should recollect. Okay. Rolling, you remember selectin. Yes, selectins are responsible for the rolling. And what are all the places actually? Adhesion, what are all the molecules are needed? Adhesion, yes, adhesion integrins. Adhesion integrins are needed. Adhesions integrins are needed. So this selectins will be expressed, there will be in the endothelium, E selectin, P selectin. And what is the counterpart? Selectin binds with which molecule in the leukocyte? Selectin binds with which molecule in the leukocyte? Yes, sialyl luvase protein on the leukocyte. Sialyl luvase or protein on the leukocyte. Then integrin. Integrin is expressed on the WBC. Integrins are expressed on the WBC. So integrins will bind with ICAM. Okay, intracellular adhesion molecule. VCAM, ICAM. Very good. VCAM, ICAM. Okay, VCAM and ICAM. The sialyl luvase protein are present on the WBC. Selectins will be present on the endothelium. Then for E-migration, which is needed? E-migration. Yes, PCAM. Which CD marker? PCAM has which CD marker? CD31. Okay, CD31, PCAM. Okay, so what is the disease if any of this process is not occurring properly? If any of this protein is defective, what is the process which can, what is the disease you can get? What is the disease you can get? Yes, you can get LAD. LAD is nothing but leukocyte adhesion deficiency. Leukocyte adhesion deficiency. Leukocyte adhesion deficiency. What are the types of leukocyte adhesion deficiency? LAD1 and LAD2 and LAD3. LAD1, which is defective? LAD1, which is defective? Yes, LAD1 adhesion is defective. Adhesion is defective. And LAD2 rolling is problem. Rolling is problem. And LAD2 rolling is problem. And what is there? It is actually defective sialoleucine. Defective sialyl luvase protein. So this is actually LAD2 is associated with Bombay blood group. Is associated with Bombay blood group. Please remember Bombay blood group. Here also the and LAD3 defect in the activation of the integrins. Defect in the activation of integrins. And adhesion, all of us know that it is a defective integrins. Defective integrins. Okay. So what is the classical history or the classical clue they can give you in the exam when they want to discuss about LAD? Yes, LAD, there will be a repeated infections. Infection of the gum will be there, and the umbilical cord infection will be there. Yeah, repeated infection. And very important thing, there is a defect in the adhesion, delay in the umbilical cord separation. Very good. Delay in the umbilical cord separation. Delayed wound healing. Very good. And also recollect that there is the cell. These molecules are needed for a cell to come out of the blood vessel. So what will be there? In the wound or in the site of infection, you will not see neutrophils at all. At the site of infection or at the wound site, you will not see neutrophils because the neutrophils are not coming out of the blood vessel. What you can get? Neutrophilic leukocytosis in the peripheral blood. In the peripheral blood, body is getting a stimulus that there is a infection. So body is producing lot of neutrophils. So in the peripheral blood, there is a neutrophilic leukocytosis. That is, neutrophils are increased. Neutrophils are increased because there is an infection, but they are not coming out of the blood vessel. So there is no neutrophils at the periphery or in the wound. Very important classical point for this LAD. Okay, so let us also have a about one more this disorder. So what will be the disease if there is a problem in NADPH oxidase? NADPH oxidase, actually, which is a enzyme needed for the phagocytic lysis of the thing. So when there is a defective NADPH oxidase, yes, you will be remembering chronic granulomatous disease. Chronic granulomatous disease. NADPH oxidase. Chronic granulomatous disease. Chronic granulomatous disease. So chronic granulomatous disease, what will happen? The bacteria will not be killed. So what will happen? The free radicals will not be generated because this NADPH oxidase is not there. The free radicals, the Fenton's reaction, the free radicals will not be happening. Free radicals, if comes only, then only they will be killing that thing. No, you will remember in NADPH oxidase, there will be a generation of the free radicals, and there will be a myeloperoxidase will be acting, and you hypochlorite ion formation will be there. This hypochlorite ion will be killing the bacteria. So this hypochlorite ion is not formed in case of chronic granulomatous disease. So the bacteria is some bacteria. Yes, okay. So many bacteria will not be killed. Bacteria is not killed. So there is a accumulation of the bacteria. What we learned, when bacteria is not being killed by the body mechanism, you get a granulomatous disease. No, so you can get a chronic granulomatous disease. In here also, we will be getting a repeated infection. Do you know any test for chronic granulomatous disease? Any test for detecting the chronic granulomatous disease? Yes. NBT, yes. NBT, very good. NBT, yes, very good. Nitrosolium. Nitro blue tetrazolium, very good. Nitro blue tetrazolium test. Okay. Also, there is a test called as dihydrorhodamine test. Yes, very good. Dihydrorhodamine test, that is actually a flow cytometric test. That is the most confirmatory test. Very good. The other test which you can get is dihydrorhodamine test, which they will be calling it as DHR test. DHR test. Okay. So this you can remember in chronic granulomatous disease. Okay. So moving on to the next image. Yes. A patient is having a right heart failure. Cytochrome C also they will check. Very good. Right heart failure. So a patient is having a right heart failure. Autopsy of the liver revealed this finding. In which you can see this alternating dark and red. Alternating dark red and normal appearing tissue. So this kind of appearance of the liver is called as the nutmeg liver. Very good. Nutmeg liver. Otherwise called as CVC liver. So please remember, CVC liver occurs in case of right heart failure. CVC liver, CVC spleen, and venous congestion of the systemic organs occurs in right heart failure. CVC lung alone occurs in left heart failure. So what will be happening? So this is the central vein. So central vein, the hepatocytes surrounding the central vein will be going in for hemorrhagic necrosis. The hepatocytes surrounding the central vein. So this is the central vein. The hepatocytes surrounding the central vein will be having the hemorrhagic necrosis, whereas the hepatocytes in the periphery will be getting blood supply from the portal triad. So they are viable. Yes. So central chronic venous congestion of liver. So this is giving you the appearance of a nutmeg. So this, what is this appearance? You will be getting this dark hemorrhage, dark hemorrhagic spots in the liver, alternating with the normal liver parenchyma. Why this appearance occurs? Because in chronic venous congestion, in case of a right heart failure, the central vein is getting congested, and the central vein is getting congested, and the area around the central vein is going in for hemorrhagic necrosis. But the peripheral area is not viable because it is getting blood supply from the portal triad. Okay, so also it can be seen in a cardiac cirrhosis, and there will be a deposition of the hemosiderin pigment. Hemosiderin pigment. Hemosiderin pigment. Okay, hemosiderin pigment. Okay, so this is the nutmeg liver. Nutmeg liver. Now, what is this thing? This is the biopsy of the lung. This is the biopsy of the lung. And in the autopsy finding in a lung, and you can see in the lung, you can see this cells which has this golden brown pigment, both in the alveoli as well as in the septa. You will be having this golden brown pigment, and the patient is having a history of left heart failure. Left heart failure, say it can be of any cause, okay, myocardial infarction, anything. So left heart failure, left heart is not pumping, so there is a backflow of the blood to the from the left ventricle to the left atrium, and from the left atrium the blood is getting congested in the lung. So this is a case of CVC lung. CVC lung, it is left heart failure. And what are these cells? These are all the macrophages, which are laden with the hemosiderin pigment, pigment. So what are these cells? These cells are called as the heart failure cell. These cells are called as the heart failure cells. So heart failure cells are not CVC. Lung means chronic venous congestion of the lung. CVC means chronic venous congestion. Chronic venous congestion. Okay, so left heart failure, you will be getting this heart failure cells in the lung. Okay, in the lung. Then CVC lung and CVC liver we have seen. If I tell the word CVC spleen, what bodies are coming into your mind? CVC spleen, what bodies are coming to your mind? CVC spleen. CVC spleen, yes, this occurs in right heart failure. This also occurs in right heart failures. Yes, it is Gamma-Gandhi bodies. Very good. CVC spleen, you will be getting this Gamma-Gandhi bodies. What is the other name for Gamma-Gandhi bodies? Sclerosiderotic bodies. Sclerosis, fibrosis will be there. Siderotic, hemosiderin pigment will be there. Siderotic bodies, sclerosiderotic bodies will be there. Gamma-Gandhi body. Okay. Then, so what is this finding? This is a structure of a aorta, and you can see a finding in the aorta attached to this aorta, and you can see mainly this white lines. You can see these white lines. See these white lines alternating with the dark hemorrhagic lines. White lines alternating hemorrhagic lines. Yes, this is a case of a thrombus. So thrombus showing you the lines of Zahn. Thrombus showing you lines of Zahn. So thrombus is nothing but how thrombus is, now we learned that thrombus is a solid mass. So what is the differentiating point between a thrombus and a blood clot? Thrombus is always antemortem. Thrombus is always antemortem. That is, it is formed only in a live tissue. Live tissue. Thrombus will always have a point of attachment to the blood vessel. Point of attachment to the blood vessel. But a blood clot, postmortem or blood clot, will not have a point of attachment. But thrombus will have a point of attachment in the vessel wall. Vessel wall. And please remember, thrombus will have lines of Zahn. Lines of Zahn. What are these lines of Zahn? These lines of Zahn are nothing but will be having pale areas alternating with the dark areas. Why there are pale areas? Pale means that white areas. Pale areas are composed of what? Pale. P. Remember, pale areas have platelets and fibrin. Platelets and fibrin. And the red areas will be predominantly having RBC. So, antemortem, point of attachment to the vessel wall. Pale areas will be having platelets and fibrin, and the red areas will be having RBCs, lines of Zahn. And lines of Zahn are more prominent in arterial thrombi. Please remember, lines of Zahn are more prominent in a arterial thrombi than in a venous thrombi. Okay, arterial thrombi, lines of Zahn are more prominent. More prominent in arterial thrombi. RBC, red zone, and platelets and fibrin. Actually, it is pale zone. It is more prominent in the arterial thrombi. Okay, so thank you for the feedback. And what is this? So this is actually a taken from a person, from a blood vessel after death. So after death, this is the finding. You can take it in a blood vessel. So this is nothing but this finding is not attached to the vessel wall. This is not attached to the vessel wall, and it is appearing somewhat gelatinous in nature. Gelatinous in nature. And this is the post-mortem clot. This is the post-mortem clot. So what is the classical finding in this post-mortem clot? You can see here, it has two parts. It has two parts. That is the red part and the yellowish part. So what happens after death, when there is no circulation of the blood gets stagnated. The blood gets dependent or stagnated. So the dependent part, that is the below part, dependent part, as containing lot of RBCs, and this gives you current jelly appearance, because the RBCs are settling down at the bottom part. Whereas in the topmost part, which has the plasma, gives you that yellowish or chicken wire appearance. Yellowish, that is the chicken fat appearance. So postmortem clot has 2 points to remember. One, it is not attached to the vessel wall and it will be gelatinous, and the bottommost part will be having a lot of RBC, that is the current jelly, red current jelly appearance, and the topmost part will be having this yellowish or chicken fat appearance. Okay. Yes. Now, this is the finding which you can get in a, see this, spleen. What you are getting this? Whitish areas. Spleen, you are getting this whitish areas. And these whitish areas, especially you can see from the periphery, these are appearing somewhat wedge-shaped. Okay, this is a classical clue. Wedge-shaped. Yes, there is a history of ischemia is there. So this is a case of white infarct or pale infarct. Pale infarct or white infarct, yes, As we recollected in case of your coagulative necrosis, this occurs in a solid organs with a single blood supply. Again, now here also heart, kidney, and spleen. Heart, kidney, and spleen. And the shape of this infarct is wedge shaped. The shape of this infarct is wedge shaped. Wedge shaped. Okay. The shape of the infarct is wedge shaped. Okay. And here, please remember, so organs with a single blood supply. Single blood supply, you will be getting this white infarct or pale infarct. Pale infarct. Okay. Then, yes, very good. Arterial occlusion. Arterial occlusion. Very good. Arterial occlusion will cause this, will be causing this pale infarct. Then, coming to the next picture. Coming to the next picture. Yes, yes, very good. Coming to the next picture, this is the lung. So in the lung, you can see this dark areas. What is this dark areas? Dark appearing very much hemorrhagic. Dark hemorrhagic areas. What is this dark hemorrhagic areas? So organs with dual blood supply. Organs with dual blood supply. Organs with dual blood supply like lung, yes, liver and intestine, you will be having this red infarct or hemorrhagic infarct. Hemorrhagic infarct. Red infarct or hemorrhagic infarct. And what? Previously congested tissues. Apart from this, previously congested tissue. Congested organs like CVC liver. Remember CVC liver, the liver got congested. So CVC liver also you will be getting this red or hemorrhagic infarct. CVC liver also you can get this red or hemorrhagic infarct. And reperfusion after ischemia, when the organ is reperfused, there also you will be getting this red or hemorrhagic infarct. Reperfused tissues, you will be getting this hemorrhagic infarct. So basically you have to understand red or hemorrhagic infarct occurs in organs with dual blood supply when there is a plethora of blood is there. Lung, liver, and in the intestine. And in the previously congested organs like CVC liver and reperfused tissues, you will be getting this red or hemorrhagic infarct. Okay. Then, yes, this image will be the all of us the favorite image and many times. And actually, this is a repeat question. Every exam, year after year, both in the NEET as well as in the INISET, they are keep on asking this question. Yes, on seeing this picture itself, we are coming this to a conclusion that these are all the Gaucher cell with a wrinkled or crumpled tissue paper appearance. Crumpled tissue paper appearance. Okay. This is very, very characteristic. Okay. Tissue paper. So what is this thing? Actually, these are nothing but these are all the phagocytic cells. These Gaucher cells are nothing but please keep it in mind. These are all the phagocytic cells. These are all the macrophages. They are nothing but the macrophages. So in Gaucher's disease, what are all the things? What is the enzyme absent? Glucocerebrosidase is absent. So there is an absent of glucocerebrosidase. So there is an accumulation of glucocerebrosides inside the macrophages, distended macrophages, reticuloendothelial system. So this gives you the appearance of a crumpled or wrinkled tissue paper appearance. Okay. And these cells can be found in spleen, liver, bone marrow. Please remember, it is not only limited to bone marrow. Bone marrow commonly you can demonstrate, but Gaucher cells can be demonstrated in spleen, liver, lymph node, tonsil, thymus, Peyer's patches. Remember, reticuloendothelial system. So organs of reticuloendothelial system, you can demonstrate this Gaucher cells. And electron microscopy. electron microscopy, you can see this. The lysosomes will be the lipid material will be containing and stored in the form of a stacks of lipid bilayer. There will be one after another stacks of lipid bilayer will be there in case of this Gaussian cell electron microscopic image. Okay, so now let us recollect in which conditions you will be getting this pseudo-Gaussian cell. Pseudo-Gaussian cells. Cells which look like a Gaussian cell, but they are not seen in Gaussian disease, some other cell conditions. Yes, CML, where else? Yes, CML and some conditions in AML also. Yes, multiple myeloma, thalassemia, Hodgkin's disease. Hodgkin's disease, you will be getting this pseudo-Gaussian cells. Very good, even in MDS also. And what is the other name for pseudo-Gaussian cells? Sea blue histiocytes. Okay, so I'll ask you one more question. A child presented with a hepatosplenomegaly and the organs are enlarged and the electron microscopy showed you zebra bodies. So in which condition you can get zebra bodies? Electron microscopy, you can get zebra bodies. Which condition? Zebra body. Yes, Niemann-Pick disease. Commonly in Niemann-Pick disease. But please remember, in other lysosomal storage disorders also it can be seen. Even in Tay-Sachs, other thing also can be seen. But commonly, yeah, Fabry also. But commonly, please remember, Niemann-Pick disease. Niemann-Pick disease. Yes. Now we are going to discuss a very important point in the genetics chapter. That is analysis of the pedigree chart and telling the mode of inheritance of this family tree. This is a very important but very, very simplified manner we will be learning and recollecting what we have already learned. Okay. So for checking what is the mode of inheritance, first we have to keep it in mind 2 points. 2 points. One important point, whether there is a skipping of generation is there or not. Skipping of generations is there or not. Whether in every generation, each generation has at least one affected individual, or in one generation there is no affected people at all. Skipping is there or not. That is one important point we have to note. And another important point we have to note is whether gender, which gender is affected, whether it is affecting both males and females or it is only affecting a particular gender. That point also we have to know. And another important point we have to know that actually what is the mode of inheritance, vertical or horizontal pattern of inheritance, So all these things we have to know. So let us see this condition. Let us see this pedigree chart. This pedigree chart, both females as well as both males are affected. Okay. So both genders are affected. And also you can see every generation, there is one person is affected. Every generation, one person is at least affected. So there is no skipping of generation. No skipping of generation. And also we can see it is a vertical pattern of inheritance. From one generation to another, the disease is being transmitted in a vertical. So it is vertical pattern of inheritance. Another important point, again, add on to the list, you can see here, father, affected father can transmit the disease both to the son as well as to the daughter. So a father is transmitting the disease to both, can transmit the disease to either son or daughter. Any offspring he can transmit the disease. So this is very important. Okay. Father transmits the disease to both son and daughter. So this pattern of inheritance is autosomal dominant. dominant. This pattern of inheritance is called as autosomal dominant. Okay, autosomal dominant. Yes. Why I told in X-linked dominant, father cannot transmit the disease to the son. Son. Yes, that we will be seeing that. That point I will be highlighting. So why I insisted this point is father transmits the disease to both son and daughter. Then the disease is an autosomal dominant pattern, whereas father transmitting the disease only to the daughter and not to the son, that is X-linked dominant. We'll see that pattern. We'll see that pattern. Now see this pattern. Both genders are affected. Okay, males and females. Okay, males and females. Both genders are affected. Both genders are affected. Then you can see that there are some skipping of generation. There are some generations which didn't have the disease at all. So there is skipping of generation. There is skipping of generation. Skipping of generations is there. And you can see this is not a vertical pattern. There is actually a horizontal pattern. That is if you've affected a recessive person, there is another person with a recessive gene, that is a horizontal. So this is a horizontal inheritance. Horizontal inheritance. So the very classical clue is skipping of generation with a horizontal pattern. Yes. In autosomal recessive, what happens? Both males as well as females are affected, and there are some generations in which you are not seeing any one person who is affected by the disease. Skipping of generation. That is in second generation. See, this is in the first generation, one person is affected. In the second generation, there is nobody is affected. Third generation also, nobody is affected. But in the fourth generation, few people are affected. So that means there is skipping of generation. So there is skipping of generation. Vertical inheritance means, so from father to son, son to grandson. Vertical pattern of inheritance means from one generation to another, that is from the affected father or mother transmitting the disease to the next generation vertically. That is from grandfather, father to son, son to grandson. So that is a vertical pattern of inheritance. What is mean by horizontal pattern, which is seen in your autosomal recessive? Horizontal pattern means a person is having a recessive gene. Recessive gene means at one gene he can't express the disease. So there is some skipping of generation. See here, there are some generations are skipped, but because they may have a recessive gene, but a single recessive gene is not expressed. Is not Mendelian is not expressed. But if that person marries another person from some other family with the same recessive gene, then that is a horizontal. Only if he marries that another person with that recessive gene, then only the offspring will have that disease. Both the genes are recessive. So the offspring will have both the genes are recessive. Yeah, that is the autosomal recessive. Skipping of generation. That is very important. Autosomal recessive. I hope this is clear. Yes. Now, coming to this pattern of inheritance. Here also you can see males and females. Okay. Both genders are affected. Both genders are affected. Both genders are affected. And very important pattern you are seeing here. As I said, there is no skipping of generation. Okay. So there is no skipping of generation. So it is dominant. No skipping of generation. You can see here in the first generation also one person is affected. In the second generation also persons are affected. In the third generation also persons are affected. There is no skipping of generation. But very important point. Father. See, the father is transmitting the disease only to the daughters. Only to the daughters. That means what? XY. Father is having XY chromosome. So father gives X chromosome only to the daughter. Father gives X chromosome only to the daughter. Whereas father gives Y chromosome with the to the son. So father will not transmit the disease to the son. X-linked dominant. So this is the X-linked dominant. X-linked dominant in which X-linked dominant in which father transmits the disease. Father transmits the disease only to daughter. Only to the daughter. Not to the sons. Not to the sons. Not to the sons. This is very important to diagnose a X-linked dominant pattern. X-linked dominant pattern. Okay. Very, very important. No, that is both genders are affected. No skipping of generation. And father transmitting the disease only to daughters and not to the sons. X-linked dominant. X-linked dominant. And what you can see here? You can see here females are carriers. Okay, you can see here females are carriers. Yes, females are carriers. Males are affected. Males are affected. Males are affected. Okay, here also you can get, this is that X-linked recessive pattern. X-linked recessive pattern. X-linked recessive pattern. And this is also a horizontal. Okay, horizontal. But very importantly, you remember this is a very classical finding to tell you this thing. Yeah, it is usually the dominant disorders only will be having the vertical pattern. The dominant disorders only will be having the vertical patterns. Usually horizontal will be having the recessive pattern only. Horizontal will be having the recessive will be having the horizontal pattern. Yeah, this is horizontal only. Horizontal. X-linked recessive. But you can see that this pattern is not horizontal or vertical. This is not important here because a person who, if it is, even a person, if it is getting a recessive gene, a male is getting only Y chromosome will not support it. So small XY, the males are getting affected. But in females, one X chromosome is normal and the other is recessive. So this female will act as a carrier. Okay. Now, let us see this inheritance. Let us see this inheritance. A father is not transmitting the disease to any of the child. The affected father is not transmitting the disease to any of the child. But a affected mother is transmitting the disease to all the children. Affected mother is transmitting the disease to all the children. You can also see here, here also the father is affected. The affected father, all the children are normal. But the affected mother is transmitting the disease to both the children. So this pattern of inheritance is the mitochondrial inheritance. This pattern of inheritance is called as the mitochondrial inheritance. Mitochondrial inheritance. Mother transmitting the disease to all children. To all children. All children. And there is no father to child transmission. No father to child transmission. Why this pattern of inheritance is mitochondrial? Because all of us inherit our mitochondrial DNA only from the mother. All of us inherit our mitochondrial DNA only from our mother. Only from mother. This is very, very important point. Okay, mitochondrial inheritance. Mitochondrial inheritance. Okay. is written. Yes. What is this investigation? They can give you any clinical scenario, whether it can be a genetic disease or it can be a hematological disorder. They can give you any clinical scenario and ask you to interpret the finding, or just ask you, what is this investigation? What is this investigation? Yes, all of you said correctly. It is fish. Last NEET exam also, they asked the name of this investigation: fluorescent in situ hybridization. So what is the function of this? Why we are using this fluorescent in situ hybridization? This test is used to detect the chromosomal abnormalities. So usually the cell cycle will be arrested at metaphase chromosome. Okay. Usually it will be done at a metaphase chromosome or even at the interphase. Metaphase is commonly done. Okay. So in this phase, what you will be doing is you will be arresting the cell cycle, and there will be a chromosome spread will be there. What you will be adding is to DNA probe, a particular DNA. You want to diagnose a particular disorder. You want to diagnose a particular genetic disorder or genetic abnormality. So the suspected genetic locus, you will be adding a fluorescent dye to that DNA probe, to that DNA locus, you will be adding a fluorescent dye. Then what you will be doing is, to that locus, you will be hybridizing the cell, the test sample, with the DNA probe. There is a test sample, and you will be adding that DNA probe now to the sample. The DNA probe is now fluorescently labeled. The DNA probe is now fluorescently labeled. Like you are incubating, you are hybridizing it. Giving a time for the DNA probe to act with the cell, hybridizing it. So what will be the consequence of this? So based after some time, you will be interpret in a fluorescent microscopy. You will be interpreting in a fluorescent microscopy. That is, say for example, here in this image, actually you are giving a green signal to 13th chromosome. Okay, you will be giving a green signal, green dye, fluorescent green dye to 13th chromosome. But 21st chromosome, you are giving a red signal. Now, can you make a diagnosis of this fish image? Yes, very good. This is a case of a Down syndrome. Why this is a case of Down syndrome? Because it is trisomy 21. That is chromosome 21. You are getting the three red signals. Whereas in 13, you are getting this two signals only. This disorder not only for genetic trisomies alone. Even in your Philadelphia chromosome, there will be translocation of 922. No, that ABL locus, you give one signal. BCR locus, you give one signal. So what happens in normal thing? Each signal will be separately. In a normal person, ABL will be in the 9th chromosome, BCR will be in the 22nd chromosome. But what happens in CML, Philadelphia chromosome? ABL and BCR will be fusing, no? So there will be fusion of the two signals in case of CML. So like this test can be applied in any of the genetic or hematological malignancy. Basic thing is to detect the chromosomal abnormalities. Fish analysis, fish technique, very, very important. Okay. Then another very recent, HER2 new gene expression, even in a neuroblastoma, NMIC, neuroblastoma, what happens? NMIC gene will be amplified, no? So what you will be getting? Amplified, you will be adding a fluorescent dye to the DNA probe of NMIC gene. In neuroblastoma, what happens? NMIC gene will be amplification. So there will be lot of signals of this NMIC gene will be there. So there are many NMIC loci are there. So NMIC are amplified in neuroblastoma. So there will be amplification. You can see more that fluorescent signals in case of neuroblastoma. Like that, this investigation can be applied to any disease, okay, to identify the genetic abnormality. Okay, genetic abnormality. Yes, very good. The next thing is a recent update. which all of us should definitely know before going for our exams. That is CRISPR technology. CRISPR technology is otherwise called as a gene editing. Okay, gene editing. What is this gene editing? It is like something like a similar to a gene therapy. Gene therapy. There is a gene which is mutated in a person. Because of this gene mutation only, the person is having the disease. So you remove that gene, replace it with a normal gene. That is gene editing. You are editing the gene. What is the name it is given? CRISPR technology. CRISPR. CRISPR means clustered. Clustered, regularly interspaced. They are clustered in one area. These genes are clustered in one area, regularly interspaced at regular intervals. Short, they are very short. Palindromic repeats. What do you mean by palindromic? You read from this side, it gives the same pronunciation. Say, for example, Malayalam. Okay, Malayalam. So you read from this direction, it also reads Malayalam. And you read from this direction to this direction, this also reads Malayalam. So palindromic repeats are the DNA sequences which, even if you read from one side also, it gives the same thing. And the other side also, it gives the same side. Say, for example, TG, TG, T. So here also it gives the same thing, and here also it gives the same sequence. These are all the palindromic repeats. So what happens in this thing? So you here in this technology, you will be using a 20-based guided RNA. See this. This is a guided RNA. So this is a guided RNA which has usually 20 base. Remember, I told it is a short palindromic repeat. So this guided RNA will be having 20 base pairs, and this base pairs will be complementary to the targeted DNA sequence. Say for example, this is the target DNA. This is the target DNA. The red one is the targeted DNA, and here the red one is the targeted DNA with some gene damage. You want to edit this area. So you have to make a guided RNA which has this 20 base pairs, which is complementary to the target DNA, See, you have made the guided RNA. It will guide you that this is the locus. But this gRNA will be binding to another protein called as Cas9. Cas9. Please remember Cas9. What is the function? This gRNA will be attached to the Cas9 protein. So this Cas9 protein will induce a DNA break. The guided RNA will tell you that this area only you have to bind. This is the damaged DNA or mutated DNA. This only gene has to be only edited. Like that, the guided RNA will say, will go and bind to it. But what will be happening? Cas9, that Cas9 protein will induce a cleave. The Cas9 protein will induce a cleave. That is, it will be breaking. Okay, it will be breaking this detected, this gene mutated. So what will be having after this Cas9 will cause a DNA break, there will be repair of the breaks will be done. So what will be having? You can have these breaks can induce random disruptive mutations. Or it can introduce you a new genetic material with specific mutation. That is, you want to correct the mutation. What in the thing? Brain, actually, it is a liquefactive necrosis only. It is there. Liquefactive necrosis, brain infarct. The necrotic area will be actually lapping as a liquefied area. Yes. So I repeat it once again. So CRISPR technology is nothing but it is a gene editing. In genetic disorders, if a particular gene is mutated, you want to remove that affected gene and you want to introduce a new gene in that place. You want to edit the gene. So what you will be using a technology called as CRISPR technology. That means you will be using a clustered, short, okay, regularly interspaced, short palindromic repeats. That is, you will be using a guided RNA with some sequence 20 base length guided RNA, you will be using it. This guided RNA will be will be binding to the place where there is a problem in the gene, which part of the gene has to be edited. That part, this guided RNA will go and bind. Okay, so guided RNA is bound to the target DNA. Now what happens? Guided RNA will be also attached to a protein called as Cas9. That Cas9 will cause a DNA break. That is, it will cut away the abnormal gene. It will be cut away the abnormal gene. Okay, thank you. Cut away the abnormal gene. So what happened? The affected gene is now removed. The affected gene is now removed. Now we are replacing the affected part. We are replacing that affected part with some new gene. You are introducing a new genetic material with precision. That's how we are curing the genetic disorders. This is actually a future of genetic therapy. CRISPR technology. Yes. Yes. Now, if I say a single word with this image, HIV, if I give you a history of HIV patient, yes, you can see this reddish patches, HIV. Yes, all of you made the diagnosis that this is a case of Kaposi sarcoma. Now, Kaposi sarcoma, the question comes, random disruptive mutation. Actually, we are interested in this thing. No, usually we are allowing it to this type of mutation, homologous end joining. So we are using this thing. If the non-homologous ends are joining, then it may introduce a random mutation. Yes. If see, homologous, if the ends are homologous, if the ends are homologous, they are appearing similar, then we can introduce a DNA with a specific mutation. But if there is a non-homologous end mutation, joining is there, non-homologous ends are joining, then that can cause an insertion or deletion, which is a very random mutation, But what we are making is, in our gene therapy, we are making the homologous ends to join. So that we can introduce a DNA with a specific mutation. The effect of this DNA cutting is either you cut the damaged part. So that part has to be joined. Now, that ends can be either a homologous or non-homologous. Non-homologous means it can join. When it joins just like that, it can introduce a random mutation. But we are making sure that it joins by a homologous mechanism, and the homologous ends are joined, and thereby we are introducing a gene with specific mutation, our point of interest. Are you getting it? Meena and Naveen? Okay. Yes. Kaposi sarcoma. Please remember, in HIV, Kaposi sarcoma is a AIDS-defining neoplasm. Now I will be asking you one question. What are all the other three AIDS-defining neoplasm? One is Kaposi sarcoma. Then the second one is primary CNS lymphoma. What is the third one? Yes, invasive cervical cancer. So these three are the AIDS-defining neoplasm. That is, if a HIV patient is presenting with any of these three neoplasms, then he has gone to the stage of AIDS. Kaposi sarcoma, primary CNS lymphoma, and invasive cervical cancer. Which is more common among all these things? Kaposi sarcoma is the most common among these things. And what is the cell of origin? Kaposi sarcoma, what is the cell of origin? Please remember, it is a vascular tumor. You can see this blood vessels. You can see this blood-filled spaces. These are all the RBCs. So this is the blood-filled spaces. These are all the proliferating endothelial cells. So please remember, Kaposi sarcoma is a vascular origin. Yes. What is caused by Kaposi sarcoma? Kaposi sarcoma caused by HHV8. HHV8 means human herpes virus 8, human herpes virus 8, otherwise called as KSHV, that is Kaposi sarcoma herpes virus. Kaposi sarcoma herpes virus, Kaposi sarcoma herpes virus. You will also remember that this HHV8, what are all the other diseases caused by HHV8? Primary effusion lymphoma, primary effusion. HHV8 can also cause primary effusion lymphoma. Yes, any other disease you know? Yes, very good. Castleman disease, multicentric Castleman disease. Multicentric Castleman disease. Multicentric Castleman disease. Multicentric Castleman disease. This, please remember, Kaposi sarcoma can be seen in a HIV setup. But in non-HIV people also, Kaposi sarcoma can be seen. It can be seen in a classic form. It can be seen in a classic form, or even it can be seen in an African endemic form or in a transplant associated form. One important MCQ you have to remember in Kaposi sarcoma, the classic form, there is no viscera involvement. There is no viscera involvement in the classic form. No visceral involvement. The classic form of Kaposi sarcoma, there is no viscera involvement. Please remember. And also remember, in transplant associated Kaposi sarcoma, there is no skin involvement. There is no skin involvement. Very important point. Okay, Kaposi sarcoma. No skin involvement in case of your transplant associated. Okay. Yes. Shall we move on to the next image? Yes. On seeing this image alone, if I'm not giving you any history, or if I am giving you a history of multiple myeloma, and I am showing you this stain, I'm not telling you the stain purposely because I want you to identify a case of multiple myeloma. And this is the polarized microscopy. Polarized microscopy. You can see such finding. Shall we break at... we started around some 7:40, no? Shall we break at 7:45? Sorry, 9:45. We'll break at 9:45 for 15 minutes break. Okay. Yeah, this is actually a Congo red. This is actually a Congo red. Is it okay if we break at 9:45? Okay. Congo red. Congo red. So Congo red stain, you can see this reddish material, homogeneous reddish material. Okay. Then under the polarized microscopy, you can see this apple green birefringence. Yes, this is the typical green apple color birefringence. Okay. This is the typical apple green birefringence. Refrigerants. And this is characteristic of amyloidosis. Congo red. What is the other stain for amyloid, you know? Thioflavin T. Thioflavin T is for amyloid, is also for amyloid. Which is the most common site for taking biopsy or demonstrating amyloid? Common site for demonstrating amyloid? It is abdominal fat aspirate. Abdominal fat aspirate, most common site for demonstrating amyloid. And which is the most specific site for demonstrating amyloid? Most specific site is rectum. Please remember, most specific site is rectum. Okay, rectum.